Hi, it's Gemma here. I'm presenting to you today the assessment of the unwell child on OMED 1401. So hopefully already you have completed the online CPD called Spotting the Sick Child. That is a CPD that takes between 6 and 8 hours, so I know it's going to take a lot of your time, but hopefully it's been beneficial to you in terms of um, just covering everything that you've done in first year and giving you a basis on which we can go on. This session is really, really important. Would I be repetitive if I said to you it's one of my favorites? It is one of my favorites. But with the pediatric, I think it's so important that we know inside out what could go wrong. And the way we do that is to know what's normal for a child at different stages of their lives. If you can spot a sick child before the OBS tell you that the child is unwell, then you are potentially saving a life. Now, people will always tell you that children decline very quick. They do this. So what that means is that the child compensates. So you can't tell, apart from little minute clues, that they're really, really unwell until they start to deteriorate. And when they do that, then boom, they're going into arrest pretty quick. So I'll recap for you regarding cardiac arrest in children. Think about it. What arrest rhythms do you guys think that the pediatric might be in when you're presented to them? Well, the answer is usually asystole or PEA. The reason being is that most pediatrics will suffer cardiac arrest from either trauma or respiratory illnesses. It's very rare that you would have a spontaneous cardiac arrest through a cardiac reason, unless the child, of course, has some pre-existing condition. So most of the time we're going to be looking at airway issues, we're going to be looking at breathing issues, and then, of course, the generally really unwell child illness, such as infection. So therefore, that means that the cardiac arrest rhythm they present to you in will usually be non-shockable. In any sense, what we're going to do today is we're going to talk a little bit about how we go about doing this assessment, what red flags we're looking for. But it's important for you to realize today that we're not just going about it in our usual ABC way. So hopefully you will have watched, or if you haven't watched, you're going to watch my session on hands-off approach and pediatric triangle. And if so, this should be a bit of a reminder for you at the start. We're then going to move on into looking at history taking and red flags and vital signs. The second session for the assessment of the unwell child is the focused assessment. So what that means is everything that I want you to look out for in an assessment of a child alongside the focus system that you've already done, whether that is abdominal, cardiovascular, respiratory, neuro, all the stuff you've already done. So there is a pattern to it. I'll teach you the new structure in this session, but then the second session is more about the focused assessment. All right, so let's move on and let you know what you're going to do today. So this is basically what I have just mentioned to you. Going to check out the history and red flags and OBS. All right, so let's test you. Whether you've done the pediatric triangle session or not, I want you to see if you can remember this, because I know for a fact that you were taught this in first year. Lee Jadwodsky, I think that's his name, I can't remember. He taught this to you in first year, and probably Scott did as well. But it's a pediatric triangle. How do we assess a pediatric patient hands off? Fill in as much as you can. Pause me and then come back whenever you're done. Yeah. All right, here is the pediatric triangle. On one side we have appearance, then we have breathing, and then we have circulation. So it's like an ABC, but of course airway is not involved here. We assume that you're going to look at the child and make sure that the airway is open and clear by saying hi or listening to them speak or cough or something or other. And then you're going to do a hands-off approach using the rest of the triangle. So for me, the way that I like to do this is I like to do checking the airway, and then I will do work of breathing, circulation to skin, and then appearance. But if you want to do ABC, then that's okay. For me, I think breathing and circulation come before checking the appearance of the child, but I don't mind if that's the way you prefer to remember it. So when we've written here breathing, it's not actual breathing, it's the work of breathing. So like in the other presentation I made for you, it's all about how much effort it takes for the kid to breathe. Circulation to skin is all about like their pallor. How do they look? How are they acting? Could something be wrong in terms of the circulatory system? Appearance is tickles. We know the mnemonic tickles. That is tone, that is interaction, that is consolability, that is look or gaze, and that is speech or cry. The next few slides go over that again. So if you have done the Paediatric Triangle hands-off approach session, then you can skim through this. If not, I'm going to skim through it anyway, so you need to do that second session. But all of the information is here on your screen so that when you're revising, you can have a little look at this. Okay. Looks like I'm teaching you the new structure first. Like it was me that wrote this like only about a few days ago, so you think I remember. So this is the way I want you to approach all pediatrics. Apart from the brand newborns, we'll be doing a different session on them. So first of all, pediatrics are kind of categorized into newborn. And for me, newborn means the placenta is in the same room as the child. So it's brand new. Then you've got neonate, so that goes up to 28 days. And then you've got pediatric, so that can include toddlers, infants, preschool, school age, primary school, secondary, whatever. Pediatrics in the law are one thing. So Marlon will tell you, when a child has Gillick's responsibility or whatever you call it. Sorry, I shouldn't say that. When the child can make their own decisions, when the child can have capacity, when the child can't. And then you've got things like laws for when they can get married, when they can vote, legal age of sex, all those kind of things are different from the way an assessment sees a pediatric. So for us, a pediatric patient is our patient that is any child up to the age of about puberty. Now, please don't check whether they have hit puberty or not. Please don't ask them. That's kind of creepy. What you need to do is assume. So get a big tall lad, nice and broad, you're thinking, right, I'm treating him as an adult, as a junior adult, of course. But in terms of the body, the recess, the respirate, anything like that, you're treating him as an adult. Smaller, you're going to treat like a pediatric patient. So it's a good idea if we know how old they are. Your age per page in the JRCAL goes up to the age of 12. So it assumes that from 13 upwards, they can get treated as an adult. So for this, I want you to be thinking of pediatrics as patients who haven't reached puberty. So around about the age of 12, give or take, either way. So let's have a look at our new structure, how we go about doing the first part of our enhanced assessment. Let me just move that over because it's kind of annoying. Is that in line? Yeah, great. All right, first step, gonna check airway, breathing, response, those kind of things. So walking in the room, checking for danger, taking it all in. Hello, my name's Gemma, I'm a paramedic, or hello, hi, what's your name? Whatever way you want to talk to kids, get them to talk back to you. They talk, they cry, they make a noise, they've got an airway, they've got a patent airway. Make sure it's not partially obstructed. Then confirm you're not in cardiac arrest. Not allowed, you're just doing all of this in your head. However, if this was your OSCE, I would want you to say that. I'm checking for danger, I'm calling out to the child, and the child answers me, I will assume he's got a patent airway. I can't hear any additional noises, therefore I assume that there's no partial obstruction. But there is some noise, so there's no full obstruction. The patient does not look in cardiac arrest. Right, that's that first bit done. If you need to correct any issues there, obviously straight away do so, opening the airway, changing position. etc. Otherwise, I want you to carry on with your hands-off approach, the pediatric triangle. So what this means is you stand and you look at the patient and you take it in. You can be talking to mum or parent or whatever, something that looks like you're not just standing there going, staring at this poor little kitty who thinks you're a bit of a freak. No, what I want you to do is to be doing something else and then observing the child from afar. Now, essentially, this only takes about a minute. You're doing all of this as you're looking at the child. It might take you less, it might take you 10 seconds. But now that you're quite new to this, I want you to think about it in every single step. So when we do this as practice in simulation, I want you to say each stage of this new structure. When you do it in your bubbles as an online learning experience, a simulation online, you're going to be working in small groups in breakout rooms, and you're going to be going through it step by step there as well. It's really important that you get this into your heads and the structure of it in particular. So pediatric triangle comes first. Like I said before, you might want to do it in work of breathing, circulation, the skin, and then appearance, or you might want to do it appearance, work of breathing, circulation, the skin. So we're going to go through that again in a moment, but pediatric triangle is what you're doing first and foremost. You can tell if there's a massive red flag there. If this kid is limp, floppy, you're not going to stand there and do the rest of it. You're going to be like, really sick child, get in the truck, let's go. So assuming that there are no issues that come up from the pediatric triangle, we're just going to go on to confirm there's no A, B, C, D, E issues. So D&E, you're thinking about disability, and you're thinking about, are all four limbs working? What's their GCS like? Are they alert, speaking normally? When it comes to E, you're going to do environment and expose. You might do expose later on when you go to look at rash. I don't mind either way, but when you're doing an E, make sure you're E in something. So if you're doing the environment, you're checking around for clues as usual. All right, we're going to go on then to history taking and observations, and then deciding if the patient's time critical or not. I will go into history taking a little bit more further on in this lecture, and we will go into observations very briefly, but this is the order to do it in. So that first little bit, right up from walking into the room until you decide this patient is not time critical, I'm going to do an enhanced assessment, is what you've got here. All right, checking the airway, pediatric triangle, confirm no ABCDE issues, and then history taken, observations, confirm it's not time critical. Now, anyone who's quite used to being out on the ambulances, on the front line or in St John or whatever else, you might be pretty good at doing history and observations at the same time here. That's okay. You might be in a situation where you're faced with a child who is having difficulty in breathing, and you might decide, nah, I want to do the observations before I do the history. That's okay. If this is your OSCE, I want you to justify that. So you're using the structure, you say, right, I'm going to do the history first and then I'll get some observations. Or I want to do my observation first and then I'll ask for history. That's okay. Either way around is okay, because I know that in real life, you're probably doing them kind of alongside each other, or your crewmate will help you with it. So that's the first part. If it's not time critical, we'll go on to do an advanced assessment. Come on. Thank you. Right. So you are going to do a few of these things in every single episode that you do for pediatrics. We want you to be thinking about them all the time. So even if a pediatric presents to you with a sore throat, I still want you to check for meningitis, septicemia. I still want you to check for rashes. I still want you to check for dehydration. I still want you to do a pain assessment to check if they're fatigued. I still want you to think about non-accidental injuries. So think of it this way. You're going to do all of this every time, apart from, let me get the cursor, this bit. This bit here is the bit that changes. All right, that changes every single time. Now you'll notice in your simulation workbooks, it might be different than this. I might have this at the top. Either way is fine. The reason I put it like this in this order is because I want you to do bing, 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 bing in every single assessment you do on a paediatric. This bit, you'll decide what you pick and choose from there. Bing, this bit thinking about it. Bing, this bit comes anyway. So we may as well just start with all the things that we're going to constantly do. You'll notice in the paediatric assessment, the structured approach, sometimes we have overlaps here. So it might be that in D, in disability, you're thinking about dehydration as well. It might be that you repeat yourself. It might be that in E, you choose expose, and then you're looking at rashes there, especially if the child presents to you with a headache or photophobia. They're going to overlap. What I want you to do, if this is your OSCE, is to make sure that you do that first bit, say it's not time critical, and then do the second bit and say, right, okay, meningitis, I've already checked for a rash. However, what I'm going to do now is more in depth. I'm going to check all of the signs and symptoms of meningitis, and I'm going to just fully explore it so that I can rule that out, even if you've already done it. Okay, hopefully that makes sense. All right, so pediatric triangle. These next slides are just a little bit of a recap. So what you're looking at in the work of breathing is the rest breath and the effort. We're also thinking about abnormal airway sounds. I want you to know what these mean. So not just what's stridor. Oh, stridor is an upper airway inspirational noise caused by a partial closure or whatever. I don't necessarily want you to be sprouting those out. Well, I do actually. I do want you to think of those and think those aloud. But what I'm getting at is that if you hear stridor, you don't just go, that's stridor. You go, oh, stridor, right. That might be an airway obstruction. Airway obstruction, that could be foreign body, that could be epiglottitis, that could be croup, that could be tonsillitis, laryngitis, pharyngitis. I'm thinking about what all of these noises mean, not just what they are. Hopefully that's clear. So any abnormal noises that you can hear, and this isn't putting your stethoscope on, this is, don't forget, standing across the room and thinking about the hands-off approach. So that's what you're doing at the moment. You're listening from afar. Look at their positioning. When people can't breathe properly, they will put themselves into a position. Even children. So sitting upright for those that already have the tone. So normally get tone from the 6 to 9 months, something like that. They start sitting up on their own. So if you've got a baby that should have tone, that should be sitting up on its own, and it's bolt upright like that, you might think, oh, there's something wrong with the lungs here. Again, the same as adults. They might be doing the tripod position. Remember that for asthma? So those who are at a standing age might put themselves in tripod. They might be curled up in a little ball. That's not necessarily to do with work of breathing, but you still note it because that's still relevant. Curled up in a little ball. Where have I heard of that before? Oh yeah, I know, appendicitis. So you're just commenting on their position as well. And the additional signs that we're looking for across the room, if their top is off, we're going to be looking for recession, additional muscle use when they're breathing. We're going to be looking for any type of intercostal muscle use. We're going to be looking for abdominal breathing, paradoxical breathing. If their top isn't off, then we'll do it whenever we're double checking any ABCDE issues. All right, this is hands off at the moment. Circulation to skin. So pulses, we might not check that yet. We might wait until we're hands on for that. But we can look at their colour. What does their skin look like? You guys are getting more familiar with what your patients look like. And you will be able to look from afar and go, this is in your head, by the way, do not say it out loud. They don't look right. And you know they don't look right because they're a little bit kind of grey or a little bit kind of pale or blue or red or whatever. But the colour you're saying don't look right. My alarm bells, that's red flags. Cup refill, again, you might not be doing this just yet if your hand's off, but you might notice, for example, if like the mum has set the baby down or whatever, left them off, you might see a cup refilling at that stage. And if it's prolonged more than 2 seconds, you'd be a bit worried. And obvious fluid loss. So part of that's going to come in history, but part of it you might see, an example of that would be burns. You've got to think of fluid as more than blood. So fluid involves diarrhea, vomiting, and it involves plasma. So those are the type of ways you can get dehydrated. So we're thinking about anything obvious. Loads of vom on the floor, loads of diarrhea in the toilet, whatever. Thinking about how much that affects that little body. So whether you've got 10 milliliters of fluid loss, that's still loads to a tiny baby, remember? Okay. Tickles for appearance. So as you can recall, this is the way we check the child's interaction, how alert they are, what is working in terms of their brain. So can they sit up and look at you? Are they too distressed that they can't be comforted? That cry, is that like that awful, awful shriek that you know this baby's in real pain? Where still is it nothing? Are they just completely silent and staring? You'll find out more information in the Paediatric Triangle hands-off approach, and there's a video that goes with it as well. So hopefully you'll all be brilliant on the Paediatric Triangle. Just before I move on, I've told you before that last year I gave 3 OSCEs that were paediatric. So we did Paediatric Respiratory, Paediatric Neuro, and Paediatric Abdo. So the people that got the highest marks in those did so much work on the Paediatric Triangle. All right, you know now, I've told you this is something that you're taking in within a minute. But by the time you talk about it and talk about all the things that could be happening and why, you could easily spend half an hour talking about Paediatric Triangle. So when you're doing this in your small groups, I want you to, at the very least, spend 10 minutes talking about everything that it could be. Okay? If you're spending only 1 minute on it, like saying it out loud, then you ain't doing it properly. So catch yourself. All right, let's move on. Right, we've done our Paediatric Triangle. We know that the airway is all okay. So we're just going to confirm there's no A, B, C, D, E issues. So here we have the obvious. A, that's pretty obvious in there. B, this is where you can get hands-on now. So if you wanted to like lay your hand on the chest or take the top off and observe the breathing, you can do that now. Again, at this stage, we're taking it all in still. So you can count a rough respirate, but you are going to take the respirate properly later on as well. It's quite likely to fluctuate, especially when you're a new person in the room, the child's scared. You know, the respirate that you look at immediately after touching him for the first time and taking off his little vest or whatever might be different from the respirate when he's completely calm. So keep that in mind. All the obs will fluctuate. Think about the noises, as we said before, and the SATs. You don't necessarily have to do the stethoscope at this point because you haven't decided yet whether it's time critical or not. So you're still taking in all the early information. So circulation, I think this is a good time to take the pulse. So child probably from about 4 or 5 upwards, I would say that you'd be able to feel the radial pulse. Less than 4-year-old, you're going to go for the brachial. All right, you're going to take the pulse in there. Don't really go for the carotid, especially in the small children. Remember, they've got short necks. All right, so you won't always find it there. So most of the time, with the smallest ones, we're taking brachial. Make sure you can find it when you're out on placement. Make sure that you can locate on a pediatric where the pulse is. Remember not to do it with your thumb because you've got a thumb in your own pulse as well. Okay, so taking pulses. We're also going to do cap refill here. We're going to not just check what the pulse is like in terms of the rate of it. We're going to check whether it's weak or whether it's full. We're going to check all the things that we did in the circulatory system, the cardiovascular system, I should say. We're going to check both pulses. Yes, we're not expecting to have a triple A, but just get into the habit, guys, with all your patients, checking both pulses. Again, not carotid, well, not both carotids at the same time, or you might kill them, but both radials at the same time. You can check for any edema. It is possible that there is heart failure going on. Normally, patients' parents or guardians will be able to tell you about that. But if there's excess fluid, you should be able to detect it and know that it can happen in pediatrics. Their skin temperature and appearance, I put that in disability really. Same with the urine output. Normal heart rate parameters, I'm going to come on to that when it comes to vital signs. But you should know that for most children, they're going to be higher than an adult's heart rate. All right, so disability. So we got to check the ABCs, and then we got to think about why a child might be behaving the way that they are, especially if they're not behaving quite normally, especially if parents says they're just not themselves. You know the classic I always talk about, there's something wrong, I can't put my hand on it. Finger on it? Yeah. So find out how alert they are. Have poo. If you're good at it, GCS. Now don't forget GCS is quite difficult for children, especially those that don't talk. So we do have a modified GCS for you to have a look at. And that's all about crying. But if you're not confident with GCS, at least you can know this child is alert, or else it's alert to voice, alert to pain, or unresponsive. If they are alert, try and do GCS if possible. If you can't do it, point out what's not quite actually right. Check the pupils, especially if they've had an accident. But check the pupils anyway. Check their position. If they've had any type of convulsion, you need to ask the parents a little bit more about that. So, is this the first convulsion ever? Is it the only one that's happened today, or has more than one happened today? Was there a recovery time? How long did the convulsion last? Did it involve their whole body jerking or moving, or is it staying still, or is it localized to just like one hand or blinking, etc.? You want to know all about that convulsion. It's really difficult when you are called to a febrile convulsion, especially if it's a new parent or parent who's seeing it for the first time, because all they can see is their poor little baby shaking and they can't do anything about it. It's violent, it's horrible, it's heartbreaking to even see. So it's going to be hard to get the information out of them as to how long it lasted for, but it's vital that we know, because that can lead to hypoxia. Hypoglycemia, blood glucose. Now, this is a controversial topic. So a lot of medics don't like doing blood glucose on children. What I would say to you is, if you have a child or a baby who is unwell and you don't know why, please do a blood glucose. So with the tiny ones, you know you can do it on the heel of the foot. You can do it on the big toe. With the bigger pediatrics, of course, you can do it on the hand, the fingers, whatever. Don't lie to them. So if they say, is it going to hurt? You say only for a tiny bit. But if they're unwell, especially through illness, unidentified illness, you need to know what the glucose is. If it's a little accident, a trip, or falling off a bike or whatever, you might not need to do it for that. That's cool. That's absolutely fine. Right, check for headaches, any disturbance in their speech, in their vision, in the way that they're behaving, anything that could indicate a neurological complaint. You want to investigate as well. So is there anything out of the ordinary, you say to parents? And they might tell you about, yeah, they were saying they seen dots in front of their eyes or something like that. Note it all down. It's all worthwhile. Okay, here's the GCS. So as you can see, GCS is only different in a verbal response when it comes to pediatrics, because some of them can't talk. So those that can't talk and cry, we do the verbal to do with their cry. So if you want a little bit more information about this modified GCS, there is an official GCS site, so you can follow that up. All right, so when it comes to history taking, we need to delve into this as much as possible. So you need to talk to the patient if you can do, and ask them a little bit how they're feeling, but most of the history will come from their caregiver. If you're suspecting a safeguarding issue or non-accidental injury or any of those kind of things, take the history anyway from the caregivers. You can get as much history as you want from other people too, but make sure you have an account at least from the person who is the main carer. All right, so when you are treating a normal case, so you're not suspecting non-accidental injury or any welfare concerns, you're normally going to be talking to the parent or the caregiver. So you've got to include them into it. Most of your information is going to come from them. In that case, don't separate them. Don't put the parent into a different room. Let the parent stay with the child. Speak to the child, listen to the child if you can do, but most of the time it's going to be the parent that's going to be telling you the story anyway. You need to ask them about how the child has been developing. So, for example, if they're at walking age, when did they start walking? When did they have their first words? Are they in the right school group, or have they been excelled or held back or anything like that? Are they able to do the motor responses, for example, riding a bike, coordination, etc.? Are there any cognitive developments, milestones that they haven't passed yet? I've written here that the etiology might be age-related. So, for example, the febrile convulsions, you don't really tend to have those much after the age of about 2 to 3. Yes, children can still have them, but they're most common in under 3s. When it comes to bronchiolitis, that's the tiny babies. So we're talking up to about 3 months there. When it comes to asthma, quite often doctors won't give a diagnosis of asthma until the child's aged about 6 to 8. So be aware of certain illnesses that will affect certain age groups. When you come to do your homework, that will be one of the sections, one of the columns that you fill in your homework. So croup, if someone says, "Oh, this child has got stridor," and it's an 8-year-old, you're thinking that's probably not croup, because croup normally happens between 3 and 6 years old. So it's really important to know what illnesses happen to what age group of children. I've been over development. Immunizations, super, super important. So there might be reasons why parents and caregivers don't immunize your children. We're aware of all this with the COVID vaccine, etc. Some people believe dodgy stories. So there's a large group of people that believe that the MMR vaccine, for example, will cause autism in later life. And a lot of people didn't take those, didn't let their children take those vaccinations. So you can ask the parent, always ask the parent, is a child up to date with the immunizations? If they say no, we'll find out why not. You don't have to be judgy about it. Just find out why not. Note it down. Is it a case for raising a welfare concern? You can debate that with the hospital. It's certainly something I would pass on to the hospital or the GP whenever I'm handing the patient over, but it kind of depends on how serious it is and what the reasons are. So the reasons being like, oh, we were isolating or something, we couldn't get out of the house for the 3rd jab, that's fine. It might be a wee bit delayed. The other way in which you can find out about immunizations is the little red book. Every time when you attend a paediatric patient, you can ask the parents for the little red book. Now, they will have it if the kid's under about 3, because it's always around. It's really good. It will tell you, their birth weight. It'll tell you their birth history. It'll tell you when they've had their immunizations, what they've had, what they've missed, etc. You want to bring that red book to the hospital with you if you're conveying the patient to hospital. But have a good nose at it as well anyway. Get to know it. Get to know what's in the red book. Quite often you'll be handed the red book and there's nothing in it, not even the baby's name. That's annoying. It's not bad, but it's annoying. Right, so we need to know about their immunizations and if they're up to date. We need to know a little bit of family history. So who do they live with? Is it just one family, or they're living with 3 generations of family? We need to know whether the family members smoke, drink, take drugs. We need to know, if there's any building work going on in the house. Those kinds of things that could affect the respiratory system or could indeed cause accidents. Drugs and allergies, we'll always ask about if the patient is allergic to anything. I would ask as well if anyone in the family has got anaphylaxis. It's quite a good idea because it might be hereditary, and it might be that parent is allergic to something, and so is child. Little sensitivities I don't really care about. Like I get a little itchy bit on my face when I have a hazelnut or whatever. Don't care about that. The child's probably not going to have that, but I'll listen to them anyway. So any allergies that they have ever experienced, any sensitivities too, but make a distinguish between them. Also, any drugs. So any antibiotics that the child's been having, any regular medication that they take. Also, if they've had Calpol, how much they had and when they had it. Ibuprofen, how much they had and when they had it. So they can be quite confusing. So don't forget there's like a Calpol 6 plus and then a junior Calpol. So make sure you see it, or the parent tells you exactly what it's called. It'll tell you the doses on the back of them. They might be different from what's in our GI Calc. They might be different from the dose of paracetamol that we would give. So it's worthwhile noting down how much they actually did give. Now, have I not put pregnancy in here? All right. So I wanted to add something in here too, is about the birthing history. So especially if they're a little kitty, you need to know, how was the birth? Was it a normal vaginal birth? Was it a cesarean? Was it prolonged? Was the child in any distress? Were there stirrups used? Were there forceps used? Sorry, I just done that. Sorry. Was there any bleeding? Was there any complications? Was the cord wrapped around the neck? Was it a shoulder dystocia, the presentation, etc.? If they're a small child, if they're quite newborn, if they're under 1, definitely need to know about all of this. Also the same if they are from multiple birth. So if it's part of twins, triplets, etc., that's worthwhile to note down too. You're probably going to cover an awful lot of this when you ask the specific questions in the enhanced assessment, but if you were looking at a patient and history taking, it might be worthwhile you start to think about these things as well. So has a child demonstrated any difficulty in drinking? Are they drooling too much, dribbling a little bit? That can be a sign of throat infection, swelling in the airway. So that's worthwhile noting. Any cyanosis you're going to note in the circulation of the skin, the colour. Abdo pain, we're definitely going to investigate further. Any breathing problems, such as periods of stopping breathing. So a lot of children can develop this in a psychological, emotional sense. So they can develop the fact that when they stop breathing or hold their breath, their parents react and give them what they want. So some do it in a psychological way, but obviously it's going to be a massive, massive, massive red flag if a child has periods of apnea and it's unknown to them. If it's unusual, they stop breathing for a while, but they're fine now. Well, that's really relevant. Even if they're fine now, that's really relevant. That needs to be investigated. So periods of apnea. Feeding problems, so if they're off their food or if they're just not able to take any food, especially brand new ones. Any type of fluid loss, we'll go over that in dehydration. Breathlessness, work of breathing. I'm so sorry, I've just looked at my bullet points. Anyone that's got OCD, please don't look at them because they're all over the shop. All right, so any type of cardiac symptoms, so palpitations or tachycardia or abnormalities, heart murmur, born with a hole in their heart, but it's cleared up. Anything that was significant even when they were born, even if the hole in the heart has covered over now, it's still significant. Any type of edema, again, we've been looking like with the respiratory system, hands, arms, legs, feet, ankles. Cyanosis again, hypertonia. So if they're really not, if they're floppy or if they're the extremely opposite as well, if they're like stuck out and they're not really moving their muscles, that can be obviously indicative of some kind of seizure. So just check whether the muscles are working as usual or whether there's anything abnormal with them all. And drowsiness goes without saying. We've talked about the illnesses that might be linked to certain ages, but think about accidents and trauma as well. Think about where the kids are depending on the size. So, like with babies and crawlers, they're going to be on the floor, so they can take things, put it in their mouth, choking. And they're both more likely to be susceptible to febrile convulsions because their hypothalamus is not yet developed. So the temperature regulator hasn't really worked. That's why the older children don't get febrile convulsions, because their hypothalamus is working. So with little babies, we're looking at respiratory illness, especially if they were born when there was meconium. That can still hang around for a little while. Scalds and burns, diarrhea, vomiting, shock, any of those will affect, obviously, the circulatory system. With crawlers and toddlers, we're looking at little accidents that they might have, because they're just bumbling around, bashing into everything. So we're looking at accidental injuries, breaks, bruises, cuts, anything like that. Again, we've mentioned the respiratory illnesses, the febrile convulsions. When it comes to poisoning there, that's basically crawling along, finding something that looks quite interesting and eating it or drinking it. Prime example is the washing tablets. They look pretty tasty, all nice and squidgy gel, beautiful bright colours. So that's quite likely to go into an inquisitive mouth if you have someone of that age that is crawling around or trying to walk around. School age, lots of lumps and bumps. But then once you start mixing with other children, you're going to get a lot more colds, flus, and infectious diseases. This is where your rashes come in as well. Like chickenpox parties, things like that. If you don't know what that is, it's basically a child gets chickenpox. All the other parents bring their child around. They have a party so that they can all have the chickenpox at the same time, so that they don't get it when they're a bit older. Get it over and done with. You don't necessarily get chickenpox again. So, that's kind of child abuse, isn't it? I don't know. Maybe it's not. But chickenpox parties are a thing. Adolescence, that's when it turns, sometimes it can turn more emotional and mental. We're thinking about self-harm. We're thinking about poisoning, like alcohol and drugs. Whether it's deliberate or not deliberate, it's still classified as overdose and poisoning. We're thinking about the size they are when they walk into cars and things like that. So, like you have a tiny child, they're going to be really severely damaged if a car hits them because it's going to hit their head and their torso. Whereas with an adolescent, it's more likely to be long bones, etc. I'm thinking about the activities they're doing as well. A lot of people want to be out and about, they're doing more sports. So you're going to be likely to get musculoskeletal injuries. So when you're going over this, think about the child and the activities that they're doing. When you go out in placement, you get a 4-year-old, think about what does a 4-year-old do? And if you don't have kids and you don't have little brothers or sisters or nieces or nephews or whatever, learn about it. So what does a 4-year-old do? Is your child at school? Are they at nursery? Are they at preschool? Do they hang out with other children? Any bugs that are going around the class, make sure you always ask that. Okay. Next bit is about observations. So I haven't put a great deal down in here because it varies so much. First thing I want you to do is to understand where you can find the vital signs. So vital signs change from age group to age group. So if I said to any of you, what is the normal rest rate for an adult, you would say 12 to 20, and you'd give me a lovely reference. If I ask you what's the normal rest rate for a child, what you should say to me is what age? What age child? Child obviously aren't all the same. And then you look it up in your GeroCalc. So what I want you to do is look it up now. Look up for a 3-year-old, look up for a 10-year-old, look up for a 1-month-old. See how it's presented. So it's in the back of your GeroCalc if you're using the pocketbook. In the app, obviously it's on a tab. I want you to have a look and see what it says there. Now, most of it's drug calculations because we calculate the drug by their weight. So it's excellent that it's written all down there so that you don't have to do calculations. When it comes to third year, Rob Slee is going to make you do these calculations in your head. So you do have to learn them then, but for now, it's a good idea to know at least where you can find them. If you get called to a paediatric, you get out your Jerical, you look at the page per age, and you see, oh yeah, 8-year-old, I would expect his rest rate to be this, blah, blah, blah. So this bit at the top, where's my cursor? Here we go. This bit here will tell you the weight that the child should be for around about the age of the 8-year-old or whatever. It will tell you what their heart rate should be within a range. It will tell you what their rest rate should be. And it will tell you what their systolic blood pressure should be as well. So worthwhile noting all of those things and having them in your head when you approach the child. You need to know roughly how things are as well. So if I said to you, what is the normal heart rate for an adult? You would say 60 to 100. If I said, what about for a 3-year-old? Would you know? If you didn't know, could you make a guess? Me, I would guess probably about 80 to 120. I don't know. And then I'd look up my Jerical and see what it is. So I'm in my mind, I'm thinking they've got a tiny little heart and they've got to get, all the blood around, so it's going to be beating faster. They're going to be respiring faster. Systolic, I don't know, probably a little bit lower. Blood glucose probably about the same. Temperature probably about the same. SATs the same. Yeah. So I'm thinking roughly what I think the obs are going to be before the child is presented to me. But what obs should you take? Should you do a full set of obs on every single paediatric patient? If not, why not? How are you going to justify that to me? Well, have a chat with your mentors about this when you're on placement as well. What obs do they do? So, as you know, when it comes to your OSCE, if I present you with a respiratory illness and you go for let's say the blood glucose first, I wouldn't be as impressed as if you went on respiratory. I'm going to do SATs and I'm going to do respirate. It makes sense, so think about it logically. What obs do you want first? If the kid's generally unwell, well, it doesn't matter, you just take the obs in whatever order you think they're important. But if it's cardiovascular, you're going to be looking at pulse, blood pressure. If it's illness, you're going to be looking at temperature, blood glucose, pulse, resps. But anyway, if we just do it in an ABC kind of way, that's kind of logical as well. So work breathing, we're going to be looking at the rest rate, depth, effort, use of accessory muscles, all that stuff. We're going to be looking at the SATs as well. So with the SATs, normal. So again, it should be above 96. Are you going to look at the end-tidal CO2? Most of the time you're not, to be honest with you. Most of the time you're not looking at the end-tidal CO2. Let's move on to circulation. Pulse, definitely. Every time we're going to be checking pulses. We're going to be checking them bilaterally. We're not just going to be checking the rate, we're going to be checking the character and how regular they are. We are going to check the cap refill. No matter what's wrong with the child, check the cap refill. It should be over 2 seconds. Now, some books will say like under 3s, they can be up to 3 seconds. If you find a book that says that, note it down so you can give me a reference. Essentially, I'm looking at over 2 seconds, unless told otherwise. Would you do a blood pressure? Well, this is the thing. Blood pressures can be so unreliable in pediatrics. It's really hard to get them to stay still. It's really hard to get a cuff that fits. It can vary so much from age to age that you can end up not knowing what's normal or not. I think when it comes to blood pressure, I would only do it if I don't know what's wrong with the child and they're pretty unwell, or if I think it's a dehydration type of problem. Talk to your mentors again, see whether they do blood pressure. Sometimes it's not worth it for the extra aggro and hassle that you're causing the kid. Sometimes it's absolutely necessary. So don't get me wrong, I'm not telling you not to do it. I'm saying think about whether it's necessary or not. If you have a couple of readings, compare the systolics. Right, we're looking at systolics for children. ECG, I'll put it in twice, but anyway, would you do an ECG? At the moment, certainly not yet. I've got other obs that I need to do before I start doing an ECG, so at the moment, no. All right, moving on. Disability. Temp. Yeah, I'm going to do a temp for every kid. Even if they fall off their back, I'm going to check the temperature. Doesn't hurt. I'm going to check it just in case there's something underlying as well. Normal temperature. I mean, that changes as well. So babies that are 3 to 6 months, sometimes they will just have a higher temperature anyway because of their hypothalamus. But think about what's significant, and normally a temperature over 38 is significant. Also, you're going to be asking about whether they've had any medication. So for us as paramedics, we do not give Calpol or ibuprofen for temperature. That's not a thing that we do. Now, it might be some of the old school paramedics that you see out and about. They might be doing that. It's not what we do. We give paracetamol and ibuprofen for pain relief. Parents will be given this as well. I'm not saying it doesn't work. I'm just saying that's how the rules are in LAS and CCAM. So find out if they have given Calpol, how much, when, what type. Blood glucose. Well, for me, I'm doing it on every unwell child. I'm not doing it on the kid that's falling off his back. No. But I am doing it on the kid that's not behaving properly. I don't mean misbehaving, I mean they're just not right. I'm doing it on them. I'm doing it on any kid that's vomiting, any kid that seems to have an illness. I'm sorry, but I'm doing the blood glucose. Now I'm doing it last because I want to get all the other obs before the kid punches me in the face and then cries and never speaks to me again. So I'm doing it last, but I am doing it. Again, chat to each other, chat to your mentors, chat to Richard, chat to Grace, chat to anyone and see how they feel about blood glucose, because quite a lot of paramedics will have a different point of view on it. GCS and AVPU, definitely. Definitely AVPU anyway. GCS if you've got it. It's in your jar calc, so you should have it. So you should be doing it, really. Pupils. So I'd like to glance at the pupils and check the round, check that they're equal, check that they're reactive. If the child's got a headache, I'm going to be looking at the pupils. If there's any trauma, I'm going to be looking at the pupils. If there's any sign or suspicion of ingestion of medication, tablet, or something else, I'm going to be looking at the pupils. The kid who's fallen off his bike, I'm going to be looking at the pupils to see whether they're equal. The kid that, let's say, ate fish, yucky tuna, had tuna fish, and got a horrible food poisoning from that, as everyone should that eats tuna. They stink. Anyway, the kid that's eating tuna, I'm not going to check in his pupils because I don't think it's something that's going to be neurological. Peak flow, yes, if it's asthma. If it's not asthma, no. If they're too young to understand, no, don't even bother. But if you've got like a 10-year-old, they might be used to doing the peak flow. So I would do that. And this is something I don't want you to ask your mentors about, because I know full well that most paramedics and EMTs on the road don't do peak flow. That's a sin. If there's asthma, and if the patient's not dying in front of you, do a peak flow, because it's something to compare with to see whether the salbutamol is working or not. Anyway, I'm going off on one. Let's get back to it. ECG. All right, so ECG, do you do an ECG? If you're concerned that their pulse is irregular, then I would do a little 3-lead. So it's actually 4 leads, but it's called a 3-lead. So you put the red, yellow, green, black on, and you do a rhythm check. That's easy, isn't it? You don't have to strip them. You can just put it on their limbs. Put it on the limbs, print out an ECG. If they have a collapse that is not witnessed or that you can't explain, even if it's something like, oh, I didn't eat any breakfast today, we do an ECG. If they've had a collapse whilst exercising, definitely do an ECG. I've talked to some of you before about Wolff, Parkinson, White. So this is a short circuit in the electrical rhythm of the heart. And this is something that we can detect because it normally presents itself as unexplained transient loss of consciousness, TLOC. So TLOC that happens when they're not doing anything, or TLOC that happens when they're doing exercise. That needs to be captured, because if you can see that in the ECG, you can save their life, because it wouldn't have been detected beforehand. So you will find out more about that in, I think it's in Richard's course, if not, it's in Rob's. But you can detect that with a short PR interval and a delta wave. Have a look at Wolff Parkinson White if you've never heard of it before. And the last one is, do you do a fast test? If it's neurological, then why not? If they understand it, then yeah, why not? Most of the time, no. But as some of you might have discovered in your neurological case studies, it is possible for children to have strokes. It is possible with trauma for brain bleeds. So if you're expecting something neurological, do it. All right, I believe the next section is about the focused assessment. So I'm going to leave this one here, and I shall see you in part 2.